This is a chronic diarrhea semiology presented by Dassi SchrDbb with reference a practical guide to ratio taking and clinical examination by Anwar Kias Sadou. Hello, so now we are going to visualize chronic diarrhea. So chronic diarrhea now is a passage of loose and infrequent stool that is for more than 3 to 4 times per day. Now for 2 weeks or more. Usually secondary to significant malabsorption. So chronic diarrhea is mostly due to malabsorption, as in case of celiac disease or in a case of a tropical sprue. So in persistent diarrhea, the cutoff line of the duration is 2 weeks. So when it's greater than 2 weeks, you already know it's chronic diarrhea. But diarrhea invariably starts as an acute gastroenteritis in an infant. So we have chronic non-specific diarrhea. So in chronic non-specific diarrhea, you have total diarrhea. You have chronic non-specific diarrhea. Chronic non-specific diarrhea is a total diarrhea. Is the most common cause of chronic diarrhea in children. So chronic non-specific diarrhea, the example total diarrhea, is the most common cause of chronic diarrhea in children aged between 6 months to 3 years who have no failure to thrive. So if you have no failure to thrive in a children that has chronic non-specific, that has a chronic diarrhea, you think of a chronic non-specific diarrhea or total diarrhea between 6 months to 3 years is usual. So short case scenario. So if you have a short case scenario where a 2-year-old child presents with a passage of loose stools containing undigested food particle 5 times per day, so undigested food particle 5 times per day for a duration of 2 months, so it's more than 2 weeks already, so it's chronic diarrhea. So the symptom occur during waking hours and become less frequent in the evening. The symptoms occur during waking hours and it's less frequent in the evening. The child is well and has good appetite and normal growth. So this chronic non-specific diarrhea, which is total diarrhea, is much more like a form of psychogenic diarrhea. So chronic diarrhea commonly occur between 6 months to 3 years. It involves passage of stool containing undigested particles about 3 to 10 times per day. So that is a chronic non-specific diarrhea. 6 months to 3 years of age and 3 to 10 times per day of stools. The second one, an adolescent male presents with a 7-month history of passing bloody mucoid stools associated with fever, tenesmus, weight loss, arthralgia, anorexia, and all that. It's possible to say here that the patient has amoebiasis, but the problem is that this is a chronic diarrhea. Chronic diarrhea, you don't think of amoebiasis again, you think of inflammatory bowel disease. So this is an inflammatory diarrhea because it is bloody. Are you getting? It's an inflammatory diarrhea and also have tenesmus. So that's why you think of an inflammatory diarrhea. But an inflammatory diarrhea which is already chronic diarrhea, that's for 7 months, you should not just think of an amoebiasis again, you should think of an inflammatory bowel disease. So inflammatory bowel disease is more in older children and adolescents. Crohn's disease is associated with extraintestinal manifestation. Crohn's disease is associated with extraintestinal manifestation such as arthralgia. You need to know that Crohn's disease is associated with pains in the joint, very important. Oral or perianal lesions. You have oral and perianal lesions. Those are associated symptoms of Crohn's disease, but ulcerative colitis does not have that. So you have oral and perianal lesions. Why? Because Crohn's disease can span all through the gastrointestinal tract. It can span from the mouth to the anus area. Why the ulcerative colitis is only in the colon. Now also Crohn's disease is associated with a form of arthritis involving the joint. Growth failure may occur with or prior to other symptoms. Now the next disease is a 1-year-old child present with a 2-month history, 2 months as a chronic diarrhea, of passing loose, mushy, bulky, and smelly stool associated with lethargy, abdominal, and failure to thrive. So this you think of a malabsorption. And then if the malabsorption is associated now with gluten introduction, you have to think of a celiac disease. So a malabsorption with gluten intolerance. So intolerance to gluten is celiac disease. So symptoms of celiac disease usually appear 8 to 24 months of age and after a gluten introduction, like gluten foods like bread, like wheat containing foods, bread, cake and all that. Another one is an adolescent present with a passage of 3 to 10 stools per day, daytime. Stooling after occurs, so not at night. Stooling often occur after each meals and is associated with feeling of incomplete evacuation. The child growth is normal. We need to know that what this is irritable bowel disease. So irritable bowel disease occur in adolescents. So it's just like a psychogenic bowel disease. Are you getting? Irritable bowel disease is just like a psychogenic bowel disease. Things that you need to know that what when you have a certain problem that is much more common in the morning when the child is awake, it's much more of a psychogenic disorder. But when you have thing, if it's common both in the day and the night, then you think you have to know that this is pathologic. Are you getting? Now, if you have this type of diarrhea that is 3 to 10 times per day when the child is awake, that is the infant or toddler 6 months to 3 years, you think of a toddler's diarrhea. But if you have that in adolescents, you think of an irritable bowel disease. Are you getting? So the first stool in the morning is usually partially formed and become more frequent during the day. A feeling of incomplete evacuation is characteristic. Diarrhea may be alternate with constipation. So diarrhea alternates with constipation, irritable bowel disease, and it's much more common in adolescents here. So the next one is a 9 months present with a 3 months history of frequent bowel motion associated with vomiting, discomfort on feeding, squirming. The mother noticed that diarrhea stops when feeding is discontinued. So when feeding is discontinued, diarrhea stops. When feeding is discontinued, there is a issue of acute gastroenteritis preceding the appearance of symptoms. So lactose intolerance, this is commonly occur after an acute infection. So you need to know that what lactose intolerance is, when you have an acute infection, you have lactose intolerance, or when you excessively eat lactose. So those are the two predisposing conditions for lactose intolerance. Either you have an acute intolerance, either you have an acute infection, or you have excessive intake of lactic acid or milk, meaning that when you take excessive intake of lactose, when you have an excessive intake of lactose instead, like in milk, you are going to have you are going to downregulate the receptors for the lactase enzyme production. When you downregulate the lactase enzyme production, you have excessive lactose that is going to be in your gastrointestinal tract. Thus the bacteria are going to act on that lactose to produce the lactic acid, which is going to result to the diarrhea, irritation of the bowels, increased osmotic pressure, and then diarrhea. Now also, if you have an acute infection is also going to result to lactase downregulation and lactase reduction. That is going to similarly result to the same pathophysiology. So diarrhea stops when feeding is discontinued or lactose is restricted. So if you discontinue lactose mostly, you are going to have a reduction in the diarrhea. Watery and acidic stools may lead to severe perianal excoriation because you have lactic acid production now. So you are going to have here the anal perianal excoriation. So the next one is a 2-month-old infant presents with 1 month history, 2 months presents with 1 month history of blood tinged mucoid diarrhea, starting gradually associated with vomiting, irritability, and poor feeding, and a skin rash. And then there is a family history of atopy. So they have told you with this there is a family history of atopy to make you feel that there is an allergy somewhere, and there's also a skin rash to make you think that there's an allergy somewhere, and this allergy is associated with food. Are you getting? So you have a skin rash, atopy in the family, and skin rash with a diarrhea. So you think of food allergy, that's cow milk protein intolerance allergy. Symptoms before age of 3 months, that's the first thing. Diarrhea is chronic, watery, with blood tinged mucoid. The next one is a 3-month-old male infant present with a passage of large bulky stools with a foul smell, one more associated with failure to thrive. I've told you that every time you have this with failure to thrive, you think of a congenital abnormality or genetic disease. The child has a history of delayed passage of meconium more than 24 hours. I've already said this before. A neonatal period and recurrent chest infections. I've already said this before. Someone you should know of cystic fibrosis. Newborn may present with meconium ILO, that's delay of meconium passage for greater than 24 hours. You are going to have child or greater than 48 hours at most. You have children have failure to thrive coupled with voracious appetite, rectal prolapse, chest infections. There may also be passage of large bulky foul smelling stools with secondary to steatorrhea. Now, history taking in chronic diarrhea, you have identification chief complaint, that is diarrhea for greater than 2 weeks. You have history, you have age of onset, you have frequency and volume of stool output. You have asked whether the low stools are interspersed with normal ones. You have timing of diarrheal episodes. You have character and consistency of the stools. Character and consistency of the stool. You have aggravating and relieving factor, associated symptom. Now, past history, we have birth history. We have maternal polyhydramnios can suggest that you have a sodium chloride transporter defect, like in the case of a cystic fibrosis where you have a sodium chloride transporter defect. You think of if you have polyhydramnios. You have prematurity, necrotizing predisposed to necrotizing enterocolitis that can present with diarrhea and bloody stools. Passings of stooling from birth, delayed passage of meconium. Past medical and surgical history. You have inflammatory bowel disease, celiac disease, irritable bowel disease, constipation, diabetes, and all that. You have medication history, which laxative can prone to diarrhea, antibiotics can prone to antibiotic associated gastroenteritis, which is Clostridium difficile without blood, and we have antibiotics associated pseudomembranous colitis, which is Clostridium difficile diarrhea with blood. You have developmental history, you have feeding and dietary history. Formula feeding, you can have allergy, can result to diarrhea, and milk intolerance. Milk intolerance is associated with 4 F's, which can result to milk intolerance. We have fiber, fluids, fat, fruit juice can easily result to milk intolerance. So we have meal preparation, dietary change, and their effect on stool parting. Milk intolerance, 4 F's. You have fiber, fluids, fat, fruit juice. Gum sorbitol, so gum in sorbitol, and you have timing details. All this can result to diarrhea, especially the 4 F's. Fibers can result to diarrhea, can result to an allergy and diarrhea. Fluids, fat, and fruit juice. Family history of irritable inflammatory bowel disease, irritable bowel syndrome, family history of allergic and milk parting, and all that. So the key points with diarrhea: a history of chronic diarrhea associated with failure to thrive suggests malabsorption condition, like in case of cystic fibrosis, celiac disease, cow milk protein intolerance. Acute exacerbation of chronic diarrhea, especially if associated with fever, is highly suggestive of inflammatory bowel disease. So fever, diarrhea, chronic diarrhea, also bloody, is inflammatory bowel disease. Nocturnal diarrhea should raise concern of inflammatory bowel disease. It's not irritable bowel syndrome. Irritable bowel syndrome is much more in the morning, while nocturnal diarrhea is much more inflammatory bowel disease. Total diarrhea usually diminishes in frequency, with irritable bowel syndrome diminishing in frequency in the night. Diarrhea that occur immediately after birth, with a history of maternal polyhydramnios, associated of a congenital diarrhea, such as congenital chloride losing diarrhea. So the diarrhea that immediately occur after birth with maternal polyhydramnios suggests a congenital chloride losing diarrhea in cystic fibrosis, for example. Chronic diarrhea that follow an acute gastroenteritis is suggestive of acquired lactase deficiency. So we have particularly in certain racial. So you need to know that lactase deficiency is much more common in African, American, and Asians. Osmotic diarrhea is characterized by a large number of soft stools that are related to eating that stop after discontinuation of feeding. That's osmotic diarrhea. It's actually with eating stop when discontinuation of food. We said lactase intolerance. We said when you have eaten excessive food and all that. We have secretory diarrhea is characterized by large volume of water which is not associated with food intake. The next thing that we're going to visualize is going to be constipation. So thanks for your kind attention.